from CHA that may be pressing, you have some questions on. We're going to talk a little bit about some of the legislative stuff that they're doing for us for the state. Okay. Can I get a warm?
I know it's the end of the day. I'm Dave Pearl. I'm the Senior Vice President. Ooh, get it there, adjust it. Senior Vice President and Chief Medical Officer at CHA. A little bit about my background. I spent 12 years surveying for the Joint Commission on the clinical side. As an intermittent survey, one day a week. I was CMO of a hospital here in California. But I also now serve on the board of commissioners of the Joint Commission. So I probably have a different perspective also from the clinical side as well as what's happening. I wanted to start out, we've got Ann and Gary here. Originally the program was for me to give a presentation. I know how it is at the end of the day, and there are usually questions that still remain out there, and we have both Ann and Gary here, and I thought we could put both of them together. We can probably answer, sometimes there's questions of what's unique about California or something unique about the Joint Commission. So between the three of us, we may be able to answer the questions, I'm sure. But I wanted to start out with a few things just to give you a heads up of what is happening, at least from we know at the board level of the Joint Commission. Between the designs of hospitals and what you have all done as engineers, you know, as Anna said, the one death is just a remarkable number to achieve in terms of fire. However, I will tell you that this year we're on track to have over 600 OR fires in the United States, and that is going to be a major focus of the Joint Commission coming next year. So while I know that a lot of that is clinical decisions and clinical activities in the operating room, it does involve fires, and therefore giving you heads up that this is going to be a focus on the Joint Commission part, just because we as board members have said that's just too high. There should be no reason to have over 600 OR fires a year in there. The other thing I wanted to make mention of, while Ann talked about the CMS and the Joint Commissions on AEMs, remember, if you're going to do that, speak to your district CDPH office because, remember, Title 22 is obsolete and old, and it doesn't allow for those things, and you have to ask for flex from your district offices. So, you know, while many of these things that Ann has brought forth are great in that CMS has moved forward and the Joint Commission obviously followed with that, we still are dealing with old Title 22 that oftentimes are in direct conflict. And if they have either an but an old regulation that is in conflict, you will get scored still under the Title 22 here in the state of California. And remember, beginning next year, all hospitals in California will have a recertification survey every 3 years by the Department of Public Health. That will occur in addition to anything you have from an accreditation organization. So that's a full survey, just as if you were having a survey from the Joint Commission or CMS. Title 22, I mean, there's statutory requirements for a CDPH to do this. They haven't been doing it regularly. They will combine the MERP survey, they will combine the patient safety survey that they've been doing all into one survey itself, and that will occur every 3 years unannounced to the hospitals. So, you know, you've got to keep record of what's happening in Title 22. One of them I wanted to bring your attention that we're catching, so I deal with CDPH in my role at the CHA, and one of the things that has come forward that seems to have a growing trend in the state of California is the issue of contracts and QAPIs, the Quality Assurance Performance Improvement aspect. CMS a couple of years ago developed a worksheet that is a very extensive worksheet to look at quality assurance and performance improvement. And when they finally implemented that, they added language to the conditions of participation CMS that says all contracts have to have QAPI. And so they're really focusing in on what your contracts have. In the past, a lot of hospitals only dealt with, it was direct patient care. We had a quality insurance performance improvement aspect in our contract language and some type of performance improvement. They are now stepping it up and really looking at those in the contract. So I know many of you have multiple contracts with different agencies, organizations outside of the hospital, just giving you heads up on that. So I just wanted to bring you up to date on a few things we're hearing in Sacramento and things that are coming forth from the hospitals. Ann or Gary, I'm happy to bring it if you have anything else to say, or otherwise we can start out with questions from anything. Yes?
So you just said that all contracts have to have copy language or.
Yes.
So the groundskeeper that mows the lawn, to what level do they,
Well,
or do we know?
you know, what we're finding, we're trying to find all the 2567s that have occurred. I have had a few that have been sent to me that I've heard of. They have just said that they wanted to see some type of performance improvement aspect. How detailed it is, there has not been any indications, and the hospitals have gone back with a plan of action, plan of correction to them, and they've accepted it. And it hasn't been as extensive as what they've had for other performance improvement for direct patient clinical care. What we're trying to get a grasp on, and if any of your organizations have had a 2567, we would like to see that at CHA, so we can start getting our arms around this as to what they're doing, and then we'll meet with Region 9 to have a better understanding where it's at. But just giving you a heads up that that is an issue right now that's occurring. At least 2 states seem to have the greatest occurrence of this, New York and California. And they seem to be focusing on those 2 states right now with the QAPI, looking at any particular contract. So, you know, you'll have to have that full list of all the contracts the hospital has, and then they can pick anything out of there. Hopefully you'll get one that has some type of QAPI in it and you'll be fine. But it is a challenge, I realize that.
Put my landscaping.
I know it.
Harder
You're gonna,
and more grass and
the noise of the lawnmower, yes, we know that.
no water. No water.
Yeah, that's right, at least in California. So, questions. You know Gary, you know Ann, and sometimes there's, you know, questions upon what's unique about California relative to any Joint Commission standards and CMS. And so I thought we'd take this time to sort of bring up the day, finish up the day, and try to answer any of those questions. Yes.
David, so where are we at with the FCC, letting the unlicensed devices operate in the same frequency as our medical patrol?
So that aspect, dear, you know that answer? Okay. So where it was is that FTC ultimately let the new regulations go forward with the understanding that if hospitals report that they're having an issue, they will go back and be able to look at that particular hospital and they'll gather information. So the regulations did go forward, but if you're having a problem, bring it to our attention too so we can share it with FTC. I know. That, you know, we sent a letter, CHA did send a letter in opposition to what the movement was, and they right. Right. So what they're saying is that we'll listen if we can identify, and if there are a number of cases that are brought forward, I think they'll reconsider it. But for right now, they let the new regulations go forward. Well, that's exactly right. Well,
Dale Wooden was really active in a lot of that as well. And I know that Dale went to Capitol Hill and Dale was on the Hill talking and putting some stuff forward too. So if you do have any of that information, it helps Dale in the case that Ashley brings forth with all of Ashley's lobbyists as well. So in addition to providing it to Dave and his group, if you could provide it to Dale, I'm sure he also would benefit from that.
Maybe we can bring back to talk to Dale. Maybe you can send out a letter of recommendation to be submitted not only to the CEOs or whatever, but also to the biomedical departments.
Right.
Just so that if anything that they're experiencing, any fluctuations in it, needs to be reported up to the CEO level and then therefore reported to him.
And it's no surprise, I'm sure, to you, the biggest problem that we have with making the arguments at the federal level is having the numbers to support it and to have the groups of organizations, groups of hospitals, groups of instances to be able to report to them and say these numbers are real. This is really something that's happening.
So they sort of took the attitude that we're going to move ahead with it because there wasn't enough evidence that came forth that there was a real problem out there. And if there is a problem, they'll reconsider it. So that's where we're at the present time.
Reactive.
Yes, that's exactly right.
You don't need brakes on the car until you
That's right. We got that handbrake that takes care of it, yes.
What about, is there any update on the State Water Resource Board, the emergency drought? Any more findings from that other than what was issued?
There hasn't, so Sheree Hummel, who handles that, you know, is taking Roger's position at CHA, has been dealing with that. There has not been any updates, any additional updates relative to you know, what has already been out there. However, where we think if this drought continues into next year, we're monitoring very, that's probably wrong, we're following very closely where they could go with the next level next year if we have routes, I mean, if we have a continued drought. And, well, we hope that, we hope that happens. That'd be the best thing that can happen. But what we're recommending, I think Sri will, if Sri was here, she would tell you that I know hospitals have been doing a lot to reduce their water utilization, obviously on the outside, but they've also been doing things on the inside too, you know, low flow toilets and a whole number of things. And so what we're recommending is hospitals to keep track of that as you implement, you install, you remodel or put new type of equipment that uses less water. Keep records of that so when we have to go to our defense, if there is going to be a continued tightening of the water utilization next year, that we have something to show. They have been very understanding of hospitals, though. I will say that they've been willing to really look the other way, not look the other way, but understand that we have to provide care. You just can't cut out water in hospitals. Yes?
Yeah, that's exactly correct. So the question is when you do replacement of anything, equipment, lighting, motors, anything, when does the replacement trigger a permit? And we have the field review or the FREER manual. It's an acronym for Field Review Excluded and Expedited Projects. That does a pretty good job of detailing or defining where that threshold is. You know, and keep in mind the context is when it stops being maintenance and starts becoming a project. That's where the permit would be a requirement. So if you're changing a ballast, you're changing a light fixture, that's maintenance. If you're changing all of them in the corridor, that becomes a project.
Similar with your, my understanding in California, the building code doesn't allow like waterless urinals and plumbing codes. Slash Pod and Timmy help change that or look the other way so that we can install those?
Well, no, and I don't know. The simple answer is I don't know. That's kind of out of my purview. But I heard Glenn Gall talking yesterday about our concerns of low flow hand washing fixtures and other water fixtures in the building that could lend itself to more infectious potentials.
I agree with that statement 100%. I mean, the toilets, let's face it, how many times have you had those low flow ones? You still hit them 3
Yeah,
times.
yeah.
You know what I mean?
Absolutely.
They're completely useless. Yeah, and then, well, the calcification too from urine, it actually builds up and solidifies, and it's all, I wouldn't want to put those in a million years. You know what I mean? They're pretty gross.
We're seeing low flow faucets and the sensors that don't work, so we don't wash our hands very long because we're tired of waiting to try to get it.
Or they
Now
stay running all the time.
we're starting to see high occurrences of Legionella and Pseudomonas growing in the
Yes.
faucets because of the low flow.
Yes, exactly correct.
Yes. No, good idea. Right. I mean, the landscape, that's a big
Landscape are
saver.
pretty- you know, that's
your
pretty s- yeah.
chiller, your cooling tower, if you can get all those modified and running more efficient, of course, it's gonna save you tons of money. That's where your money's saving, and that's where your water's saving.
And if you haven't heard it from an OSHPD perspective, we did file emergency regulations recently requiring compliance with water saving considerations and water saving laws for irrigation and outside water projects, but not necessarily applying to internal projects.
But that's for new projects, right? Not for
Yeah,
new projects.
yes.
And likewise, we have been in discussions with CDPH because in Title 22, there's some things that we think could potentially reduce the utilization of water if they were willing to modify Title 22. So we're taking a list of those and starting to gather. I don't want to say what they are because I don't want everyone to get hopes that we're going to do, but we are in discussions. Sheree and I have met with CDPH to broach that topic, and they're exploring what they're going to do. But you know how fast Title 22 has changed, so don't hold your breath. We'll probably over the drought before that's done.
David?
Yes.
Is there any update on the, remission, reduction program? Last it was in Congress, right? And it said it was in remission until September 8th. Anything on
I think you're speaking, are you talking about the 2 midnight rule issue, or is that what you're speaking to? I'm not sure.
It was just recently published from you guys. It just came out, like you said, it was in remission until the 8th, so I just didn't know if there was something that you could report on here.
Well, the La Venta is, if you're speaking to that, and I think you are speaking to the admissions for the 2 midnight rule, I think that's what you're speaking to, is that it, right? So they have put a delay into looking to be penalized until, they've given to the end of the year to begin looking at that part of it. The second part of it is that they have moved the review of those from the QIO, the former QIOs, from the previous QIOs such as HSAG, which was here in the state, to the new one, because HSAG moved over to QIN. I know these a lot of words. Quality Improvement Network. They've moved them out of that role and they turned it over to La Venta, who we've been in discussion with. They haven't been given their directives yet, clearly, upon what CMS is going to be looking at. And Alicia Keith from our Washington, D.C. office, and myself and Debbie Rogers have been in communication with them. We're hoping they're going to get some guidance from CMS soon as to what they're going to be looking at into the future and reviewing those. So it still is up in the air. Yes, Gary? You don't have to call me, that's fine. You can call me Dave. You know me well enough, yes.
If you could maybe just kind of give a highlight of CHA's, what's the process by which you guys work with the various agencies like OSPOD, Department of Health, Joint Commission, and do you have involvement with CMS, or just kind of, what all is you guys' role in relation to regulatory bodies?
Well, for those of you who do not know, the California hospital associations are very unique in that we have 4 associations in the state. We have 3 regional offices, which consist of the San Diego and Imperial Hospital Association of San Diego and Imperial County, the obviously San Diego and Imperial County, the Hospital Association of Southern California, which is Los Angeles Basin, Orange County, all the way over to the Arizona border if you go out directly from LA County to the east. And then from Santa Barbara north, that in all Central Valley is a Hospital Council of Central and Northern California, otherwise known as the Hospital Council. Those 3 regional associations work with the local hospitals closely on a lot of local issues. So for instance, there's been some discussion upon new tax onto transportation tax upon hospitals in San Francisco. So they work with the local government there. Then there is the California Hospital Association. We all work together. We're like a federated model. We're like the DC, Washington, DC, and then the federation, the 3 regional associations, like 3 states. We then deal much more with the Sacramento offices and issues, and then with Washington, DC. We have a full office in Washington, D.C. with the staff there. We work closely with the Joint Commission on a number of things. WAPI is one of them that we've been working with them on, and there's several other things. There's the glucometer issue. I'm just trying to think of several of them that we worked with the Joint Commission closely. Then with regards to our operations in Sacramento, we deal with all of the agencies in Sacramento, whoever we need to deal with, whether it's OSPOD, whether it's OSHA, Cal OSHA, which has some unique characteristics in California that is different than any other state, especially with the aerosol transmittable disease became a big issue under the Ebola crisis. And then CDPH, we have regular meetings with all of those state agencies on a regular basis. And in Washington, D.C., we work with and of course we deal with the legislature in Sacramento. Likewise, we deal with the delegation from California, senators, and all of our Congress members that are in Washington, D.C. And then we have direct line and communications with CMS and FDA some too. So when there are issues that come up, we oftentimes will try to partner if we can. If it's in the Washington office and we think it's a national issue, we'll partner with the AHA, the American Hospital Association, or others, and to bring a topic forward for discussion. But when we're dealing with things in the state, we're pretty much, when it becomes a state issue, CHA deals with it directly in Sacramento. Does that make sense? So when there's things like you want to bring up, you know, that's what we're here to help you with.
You get partnered with the CDC as well?
We did. I had a lot of discussions under the Ebola thing. I was on probably quite a long number of hours of late night with the CDC because California took a unique approach onto the personal protective equipment, PPEs, in California, which still stands under the Cal OSHA regulations. So we do deal with CDC when we have to too. Yes.
Can I add to that, Dave?
Yes, go ahead.
From a OSHPA perspective, and I can't speak for other state agencies, CHA is truly one of our partners in helping us do the things that we do. And I'll give an example. Most of you know I'm primarily responsible for writing the regulations that go into Title 24 for healthcare, fire and life safety regulations pertaining to healthcare. There's an interesting law that says in California, only the state fire marshal is permitted to promulgate regulations relating to their occupancies that they regulate. So the process for me to propose new regulations is to submit them to the state fire marshal, and they carry them forward to the California Building Standards Commission. There have been numerous broken code issues that we've been aware of for the past 3 years or longer. And over the past 3 years, I've met with Kevin Reinertson and others at the State Fire Marshal's office to fix these. Well, in the code rulemaking process, we're at a critical spot right now where all the regulations went to the Building Standards Commission for public comment. And right in the midst of this, Kevin retired. He didn't retire, he went to a different agency. And a new guy that came in said, I don't know anything about what you're talking about, and we're not going to have enough time to get your regulations into the package, which really frosted me personally because I've only been working with him for 4 years to try to get these things fixed. We approached CHA, and Cherie and Roger partnered with us and went over, and those regulations, they called the state fire marshal, Tanya specifically, and said, hey, this is important to us and this is important to healthcare in California. And they said, you know what, I think we're going to be able to find the time after all. So it was a huge partnership, and we couldn't have done it without them, and I just wanted to share that perspective.
Hey Gary, is there any plans for OSHPA to accept or recognize NFPA 101?
Well, what I do is make sure that the California codes mirror NFPA 101. So codes in California are never less restrictive than NFPA 101. And the 2015 International Building Code, for instance, has some new provisions that are extremely less restrictive than NFPA. These same provisions were presented to NFPA, and NFPA said, what, are you crazy? We're not going to do this. And so they never adopted them, and they're not in NFPA 101. So we amended the IBC to make it match NFPA. So simple answer, no, but we do make sure that they are at least
How does CGPH, there are waivers from CMS. One example is CMS issued a waiver for emergency generator testing.
Correct.
Manual testing for 2 hours.
1.5. It's 1.5.
CGPH is not accepting that. Is there a reason behind it? I mean, is there any law?
Have you tried to ask for a flex from the district office? Did you approach them or not?
I don't think that's really
You can ask them, but CDPH came out with, what's the name of the letter?
The AFL? AFL's letters.
They actually stated that they were not going to accept the reduced generator.
Okay. So they made a statement, then they're not going to change, they're going to stay with the current Title 22, so then you won't get a change on that. That's right.
You're having QMD saying that you cannot run the generators more than
So can I, without giving you false hopes, can you there may be a point in the very near future that we're going to seek from all of our member organizations things in which there is either conflicts between current practices from CMS and Joint Commission and Title 22, or in things in which are missing, or they're just not congruent, and items that would make your life better. Keep track of these, and we may in the near future need as much input from all of you to say, that's a perfect example. This is an example of something that the national standards have changed, but we still have a state regulatory component that is not current, where everywhere else in the country is doing it differently. And those may be, there may be an opportunity to change that in the future. So keep track of that if you can, because it will be a short notice for us to gather all that information and bring it forward. Yeah, I'm sure you can. One other thing I wanted, you asked about how the relationship between CHA and the Joint Commission. We work with the Joint Commission. I'm on the Board of Commissioners, but I'm very careful to have that firewall because we are agnostic with regard to any accreditation organization. So we deal with DMV, we deal with CIHQ, we deal with HFAP. We treat them all the same. But I do serve on the Board of Commissioners, and I'm on the Executive Committee of the Joint Commission, so we do have regular representation at the Joint Commission level. But we are totally agnostic without any, showing any favoritism or recommend one over the other. But we do have a
And I can
direct route.
attest he abstains too. I've been in a number of those meetings where he's abstained because it's California related.
There's a potential conflict of interest. I have to obviously do it, but any other particular questions that I can, or any of the three of us can answer?
Is there a time frame where we, well,
We have a project we want to start.
yeah.
We get a permit, it's still money, but we haven't got the final bill from.
Yeah, so most of the time when we're looking at outstanding fees, we're looking at past due fees. So if it's been 90 days and you haven't got an invoice yet and you haven't, yes, understood. So on the flip side, if you need occupancy and you got a change order last week, well, that probably, there's obviously fees assessed because as soon as you get a project number, you have assessed fees, but you haven't even received an invoice to pay those. We are not going to hold you up occupancy in that situation.
They held it up because they wouldn't give us.
No, they didn't. They shouldn't have. So again, we're going to look at the entire context because I have this conversation all the time, as you can imagine. And I've had people screaming at me on the phone, literally saying, we need occupancy and you guys are holding us up. And I go look at the project and they've owed us fees for 90 days, 120 days, whatever. So there has to be, we need to partner together as well. This has to be a two-way street for us to be able to give you the service that you expect and vice versa. Yeah, if that happens, if you have a last minute change order or a last minute fee that gets assessed and our staff are not willing, first off, at the compliance officer level or the fire marshal level, we've told them this is a deputy division chief's decision anyway. So they should be referring it to the regional compliance officer or to Gordon for a final decision anyway. And that happens very quickly, as you know. That phone starts ringing off the hook and a decision is made pretty quickly. Yeah. I'll tell you a story, and without naming names, one of the rather large healthcare agencies, we asked them to come meet with us because they owed us $17 million in fees. When they came to the table, they said, we had no idea we owed you that much. Well, that's concerning to me, that they didn't know that they owed that much in fees. $17 million notwithstanding, they didn't know it. There's a breakdown there that we needed to work through as well. So, yeah, 17,600,000, same thing, right? Yeah. Decimal points, that's all. Anything else?
Anybody else?
Come on.
Forever holding peace.
Come on, Wa-
All of you are familiar with that Sheree Hummel has replaced Roger Richter, and she's your lead contact. But at CHA, we try not to work in silos. And Sheree will just walk down to my office and say, hey, this kind of drifts over on the clinical. What can you tell me? So we try to work across the silo type of effect that oftentimes occur in large organizations. But she's doing a great job, and Roger's enjoying retirement too, I will tell you.
Well, we really appreciate you guys coming out and giving the opportunity to present everything to us and giving us the opportunity to speak to you guys as well. So, appreciate it.
Thank you.
Thank you.
All right, it's been a long day.
Been a good day, though.